And Dubai is like a second home to me.
Yeah, if you were stay there, you will not have Ferrari, right?
So this part is completely deletable. And it's our job as dentists to educate patients. Wow, this guy, amazing. And all the patients look at me and go like, maybe he doesn't know how to do veneers, that's why.
Did you make veneers?
No, I don't. Do you?
No.
See, exactly. That's what we're talking about. Angelina Jolie.
Yeah.
And she's like, I want to look like her after the treatment. You need a plastic surgeon. You don't need a dentist.
You don't need me.
Exactly. Satisfaction you get from an impression coming out with finish lines well-defined. And in my lectures, I always ask 3 questions. Check this out.
Hello, everyone, and welcome to Charismatic Podcast. Today's guest is the phenomenon Dr. Amir Hadjhamou. Dr. Amir, he's a consultant prosthodontist, and he graduated from Lyon University. He has a master's degree in aesthetic and prosthodontics. He's also a director of Elite Academy, and he's making a lot of education, and he's in Sharjah University in the postgrad program. So welcome with me with Dr. Amir. Dr. Amir, thank you for being here.
Thank you, Ayham. Thank you for having me today with you.
Thank you. Dr. Amir, what do you do for a living?
Quite a good question. Depends. During the day,
Yeah.
I'm a dentist, obviously, so I practice. I'm a private practitioner. I mean, as you said earlier in the introduction, I do a lot of teaching. I've been teaching at the University of Sharjah since 2008. More recently, I've been involved into the postgraduate program in prosthodontics at the University of Sharjah for the last maybe 5 years or 6 years. We've had 3 batches that graduated successfully. I'm also involved in education courses, training programs. I mean, you probably have heard of the ADAM course, which is an acronym for Aesthetic Dentistry and Applied Methods course. And it's also the name of my firstborn child, by the way.
Oh, really?
Yeah. My first child is my oldest son is named Adam. And
Same as me.
Okay, so you have an Adams as well. Yeah. So there's a lot of Adams nowadays, like if you're in a park and you got kids playing and you call Adam, you got 10 kids turning around. It is what it is. But I launched the first, I think it was one of the first veneer courses ever in the UAE back in 2011 about veneers. So I've been very much involved in education with the Elite Academy.
At that time, like only few people knows what is veneer.
Yeah, it was not as common as it is now.
Yeah.
It was not as common.
And that's what takes you to Lyon? Why you choose France?
Actually, very good question. So I was born in the States. I hold an American passport, and the logical thing would have been to, go to the US, except that the tuitions in the US are way, way too high. So at the time I was a student, I didn't want my parents to pay so much money for my studies and stuff. So I chose a better option, an easier option, financially at least, which was France at the time, being Algerian. I'm from Algeria, so I speak fluent French ever since I was a kid. So it made more sense for me to choose France as a destination over the US. Now, the choice of Lyon specifically, as silly as it sounds, it was mainly related to football. So 2003, 2004 was the golden ages of Olympique Lyonnais, which is was at least one of the best clubs in France at the time. And, I was so much into football. I still am anyways. So I was in between Lyon, Toulouse. Paris was out of the question. Paris is a very busy city. You don't want to live there. I mean, It's beautiful. Don't get me wrong. It's nice to go visit, spend a couple of weeks in Paris, but to live in it is a different story. So I was in between Lyon, Toulouse, and Nice. Nice in the south of France, beautiful city by the Mediterranean, but not for studies. So I was like, maybe it'd be a smarter idea to just go for something a bit more realistic. And I fell in love with the city, to be honest.
Really?
And the food is really good.
Generally in France, the food is very good.
Yeah,
right?
well, Lyon was chosen 6 years in a row world capital of gastronomy. So technically, best food in the world.
You think so?
Taste-wise, yes. I mean, again, Middle Eastern food has its own. It's
a Middle Eastern anyway. France is Middle Eastern, right?
Not really.
Not really. But I mean the Middle Eastern.
Yeah.
But I believe they said, like, they make this statistic, like Spain was the best food, then Italy, then France. I don't know if it's true or not.
It depends how do you define best food. So usually when it comes down, I don't know, well, to me, I would say North African, Middle Eastern food, Algerian food is the best. But it's what you get used to, obviously. But when it comes to tasting, if you want to have fine tasting food, I think the French are pretty good at it, to be honest.
Really?
Yeah, we have to give them that.
Because you study there, maybe.
Maybe I got used to their food as well. The portions are small though, so don't expect to
That's the
be
problem.
full. Exactly, the portions are very small, but they have good food. Let's give it to them.
Yeah, and how you like the studying there, or do you suggest the student to think about it?
Oh, the experience was amazing. The only problem in France, I think it's very much the same as Germany, because most of universities, or all universities, are actually public universities. So the teaching takes place in French. So you need to master the language. You need to make sure that you speak fluent French. Not only that, you don't have the option of having English programs, but studying is almost free. Like you don't pay nothing for it. You know, it's as a matter of fact, when you graduate and you start specializing, you work in a hospital, you get paid for it. So it's even better. So the level is quite good, up to date to a certain extent. You know, it's they're up to date research wise. At the time we had the dean who promoted research, and we did a lot of research work in vitro and in vivo, so on patients and as well as in labs. So definitely, if learning languages is something you like, I'd recommend French as an option.
As a dentistry.
In dentistry, in all fields, and I would say more specifically in dentistry because that's what I know of. Of course, what happens is different universities in different cities have a reputation on different specialties. For example, if you go ortho, you have one of the best programs in Paris. If you go for pros or aesthetic dentistry, then you have the south of France that's more popular with that. So it depends on what area of dentistry you want to be specializing in. But definitely, I would recommend France as an option to study in.
But you're not stuck there. You did not. You just came back here or to the state.
Well, I had a trip to the US, and at a certain point, I was in between, moving back to the UAE or settling down in France. And I remember very well at that time, my family's been here for years, and Dubai is like a second home to me. And I was in between, settling down and, with a little bit of pressure from the family. Why don't you come back, give it a try? You got friends here. You have, you know your ways around and stuff. I was like, okay, you know what? I'll come, but 2 years only.
Yeah.
That was back in 2007 or 2008.
It was a good decision, actually.
And 2 years turned into 17 years, and I love it here. I love it here.
If you are...
No place like Dubai,
yeah, if you were stay there, you will not have Ferrari, right?
Probably not. You would be going to the taxes mainly.
Yeah.
No, but Dubai is a special place. It's a special place. It has a lot of privileges you don't find anywhere else in the world.
What do you like the most here? The most? You have a family here, right?
Yeah, my family, my kids are born here. I think the best thing about Dubai, first of all, is safety. Safety has no price. It's priceless. Being able to go out at any point of the day or night, not worrying about your family, about stealing. This is priceless, to be honest. So that's the number one thing I look at. The multicultural aspect. When you have a child that goes to school in primary school, and then they're like 28 pupils, and you have 15 nationalities. That's the word coming to you. It's amazing,
Yeah.
It's just amazing because most big cities, you'll say, yeah, but that's the same in New York or Paris or London. What I felt, from my experience in France or the States, is people live in communities. They don't really interact. I play football twice a week with guys from work and different places, and we're like 12 men playing football with 6-7 different nationalities. So you got Middle Easterns, then Danish guys, South Africans. It's a bunch of nationalities that kind of mingle, and that multicultural aspect is amazing about Dubai.
Yeah, that's true.
And the quality of life, of course.
Yeah, the service.
That's
amazing. Yeah, everyone is enjoying them. Just yesterday, I was talking with one of my friends. He's a successful man. He has a chain of clinic in Saudi.
Okay.
And yesterday he was in the state. He said, I will call you. Then he said something. He mentioned something very interesting to me. He said, you know why I go to the States to make vacation, not Europe?
Mm-hmm.
I said, why? He said, because of the customer service. The customer service in the USA, or not all of the USA, some part of the USA. And in Dubai, they are the best. You feel like there is hospitality, the people taking care about you. In Europe, there is quality, but there is no customer service. And I notice it. Even if you go to 5 stars hotel, you still have to stand up in the queue waiting for the 2 reception. One of them pregnant, the other one is has some problem. So yeah, you don't feel so. The customer service and the quality. Which one from your view, which one is you feel like more important? The customer service or the quality? And you're a business owner. You are running business here, right?
I think they're both as important, to be honest. I mean, this is something I say to our students, for example, at university or the dentists we work with. I tell them, you know what? At the end of the day, when you have a patient, I mean, I'm not your boss. You know, the patient is your boss, because it's, even though we're in the healthcare industry, you know, we are healthcare providers, we're doctors, but at the end of the day, when a patient comes to a private practice, they expect a certain level of customer service. So that customer service applies not only in hotels and resorts, it applies in our practices on a daily basis, because these patients expect a certain service to in return. So I believe they're both as important. Now, quality should come along, because obviously this is what makes a long, sustainable reputation. Coming back to dentistry, obviously. Because if you have the quality of service and then the service itself, and the patient is happy with the experience they have once or twice from a service point of view, but then they don't have the quality of care they were expecting, you lose a patient. So one is short term, the other is long term, and they both come together. They're as important to one another. Important.
Coming to the quality, you see now in the dentistry, this era of dentistry, you see the promotions and they're making very cheap veneers. So what do you suggest for the patients? How can they differentiate which one has better quality? I mean, it's a difficult choice for them, right?
It's a question I wish I had a straight answer for. It's something I put myself in a patient's shoes, and I realize that it's not easy to actually know which one is good or what's the best way to do. I mean, you go on social media, you open up, and as you said, you find crazy offers with a price difference that ranges from, let's say, 1,000 for a full mouth veneer to, let's say, 12,000 per veneer.
Yeah.
And the patient is kind of lost in that process, and he doesn't know which one to go for and how to choose which one would be the ideal kind of treatment or dentist to go back to. And I feel bad for them, but I think this is something that has to be implemented in dentist education over the years. And this is something I started talking about more in my courses, which is the question of ethics versus aesthetics. You know, I mean, unfortunately, dentistry, especially with the new era, as you said, of cosmetic dentistry and smile makeovers, it has taken a commercial turn rather than a medical turn, which is okay. To a certain extent. But we can't forget that we have a mission to deliver. We have to provide healthcare. We cannot mislead patients into making them believe. I mean, one of the offers I saw just recently is a 99 years warranty.
99 years warranty.
Yeah, I mean, how crazy is that? You know?
How can you guarantee the veneers?
And it's kind of funny because I've always wondered, I mean, have you ever seen an orthopedic surgeon giving you a warranty on a hip replacement? No, they don't. So why do we have to give warranties? I mean, I tell my patients the moment I put my veneers on, I mean, no, I don't give a warranty. They ask me, how do you have 3, 5, 10 years warranty? I'm like, no, I don't. Of course, I have a moral commitment. That's a different story. I have a moral commitment towards my patient that if anything happens for any unforeseen reason to the restorations I've placed, and they break within the next, let's say, 2-3 years, I will replace them for free. I won't be charging the patient. But that's a moral commitment. I wouldn't want to call it a warranty, because we're treating human beings at the end of the day. No heart surgeon will give you a warranty on a prosthetic heart valve.
No.
So why do we have to give warranty? Why do we have to fall into that commercial trap, trying to attract patients with lifetime warranties and so on? So I'm shocked, and at the same time, I feel bad for the patients because they don't really understand what's going on. They wonder which one is the right way to go to. But I would recommend people to document themselves, read a little bit more. I mean, I don't know, you've seen some of those 3D, 5D, 7D, 9D veneers that you see out there, and you know.
Is the degree of the clinician is important? Does it play?
So as a consultant or as a specialist, I would be like, yeah, but no, I don't think so. I mean, I've seen general dentists who do a very good job, maybe even better than a specialist.
But they cannot do everything.
No, I don't believe you can actually be good at everything you do.
Yeah.
So that's the beauty of specializing, because when you specialize, you focus on one area. For example, I do prosthodontics and implants. That's it. I stop there. if you're an endodontist and you focus on one area. But even as a general dentist, you can eventually choose to focus on one specific area and excel in it. So, if you could be a general dentist who enjoys, let's say, root canal treatments, and then you focus, you train, you do courses, you develop your skills, you read, you document yourself, and you could be as good as a specialist, I guess. At the end of the day, it's very important to focus on one specific area and improve, excel in it, and then take it to the next level, maybe a few years down the line, explore other possibilities, and that's for general dentists. But as a specialist, again, it's easier because we're already confined in our specialty. So we rarely go out of our zone of comfort. We focus on the area we're specialized in. The degree what I believe is mainly the self-judgment of a healthcare professional in general, not only dentistry. You should know your limits. You should know when to stop. You should know when to say, oh, this is beyond my limits. Let me refer to someone who's got more experience in that. And
that's honesty.
That's honesty. Yeah, that's honesty to yourself to start with, and then to patients. Because at the end of the day, you can't be good at everything you do. So put limits to yourself. Tell yourself, you know what, this is a little bit out of line. Maybe I should refer the case to X or Y or Z. You know what I mean?
Yeah. So when the patient comes to you, sometimes you need to give them many options for the treatment planning according to their packages, according to the time frame which you are going to do. But sometimes they don't understand that they have to go, for example, first to the orthodontist to make the orthodontic treatment, then they come to you, then to the implantology. So this one, we call it interdisciplinary, right?
Absolutely.
So how you educate the patient to take the best option from the options which you give?
It's actually a very good point. I'm really glad you brought it up. It was in the back of my mind. I was like, I hope he talks about it. Then I forgot about it.
I saw it. That's why.
And I was like, seriously, are you a mind reader of some sort? So yeah, I think it's something very important, and treatment planning is the most crucial thing in dentistry. Whether you're doing cosmetic dentistry, prosthodontics, aesthetics, implants, whatever it is, you have to properly treatment plan. And the best way to decide is to select less is more. The less you do, the better it is. So having a minimally invasive approach, try to preserve tooth structure as much as possible. When a patient comes for an elective procedure, for example, there's a test called the Daughter's test. You know what the Daughter's test is?
What is it?
So it's basically you ask yourself the question. You want to give a treatment to your patient, and you ask yourself, okay, what if that patient was my daughter? Would I be doing it? If the answer is yes, then you go ahead and do it. If the answer is no, then you don't do it. Now, if you don't have a daughter, you could do the son test. You could do the mother test. You could do the father. Don't do the wife test. It's not going to work.
Definitely not.
It's not going to work. So obviously, and it's quite easy because you put yourself in the patient's shoe and imagine it was one of your family members. And what would you prefer for that patient? And obviously, I would start from the least invasive procedure. So if a patient, let's say, has got slight crowding, rather than shaving down the teeth and putting veneers or bondings on it, I would definitely offer and put on the table orthodontic treatment. So Invisalign, especially now with aligners, patients accept more, aligning teeth rather than conventional braces because it's a plastic tray, they can take it out and all of that, so it's more convenient. So I would definitely go with aligners. So it's about how you present the treatment to your patient. If you put it down on the table, you talk to your patient. I've had patients, one of the most important things I look at when patients come for smile makeovers and elective procedures is the age.
Yeah.
The age of the patient is very important. If you got a patient that's 22, 23 years old, think about it. I mean, if you've done a great job 15 years down the line, things start deteriorating.
Yeah.
Exactly. So the veneer becomes a crown, and then 15 years later. So age is a very important factor. When someone is 60 and wants to get a smile makeover, then you know what? Why not? Because if you do a good job, 15 years down the line, the patient is 75. Another 15 years, the patient might not be around.
Yeah.
So what I'm trying to say is, age of the patient is an important thing you look at. I would not hesitate to talk the patient out. And I've refused patients.
Why you reject them? Because they have nice teeth?
Because they have nice teeth. I mean, I've had, it's less common now, but 5-6 years ago, we had this trend of youngsters coming age 22, 23, and want to get veneers just because their friends got veneers. And the teeth are perfectly aligned. They just want to have very white teeth. I mean, no, I'm not going to do it.
Don't surprise, because I know one of the clinicians here that he prepared the teeth for 18 years old patient. She's not a patient, actually. She just want to make her teeth smile. Just be patient. And he just prepared, 18 years old. So teeth still moving. And yeah, it was like this situation. So we have actually to educate the patient that they shouldn't go for this invasive treatment.
Of course, there are cases, though, for example, someone who comes with fluorosis, tetracycline discolorations, even though a patient is young, there are cases that are indicated by the book for veneers. But these cases constitute like what? 0.5% of the patients we see.
Yeah.
99.5% of these youngsters come just because they want to have whiter teeth. And it's our job as dentists to educate patients. Because if I say no and the dentist next to me says no and the one after me says no, then the patient will understand that no, this is wrong.
How about if you say no, then the next dentist will say yes?
So I'll tell you, it depends on how much time I take to convince my patient not to do it. And I usually take my time with it. You know, especially when a patient, sometimes I'm explaining, I'm like, no, you're too young. Maybe you should do this or that, but not this. You're still young. Wait, maybe 10 years down the line, you can eventually consider doing veneers, maybe later on. And I can read the facial expressions of the patient. Some patients are like convinced. They look at me, they're like, wow, this guy, amazing. You know, he's genuine, he's honest, he's not after my money. So they trust me. These patients will send me countless number of patients. And other patients look at me and go like, maybe he doesn't know how to do veneers. That's why.
What do you do in this situation?
I read it. And with these patients, I take even more time. So I start opening articles, showing pictures.
Oh, really? This is from your time?
Yeah, it's from my time. Yeah, it's from my time. But I believe it's our job because, you know, at the end of the day, we're healthcare professionals. So it's our job to take the time to educate the patients because, as you said, maybe that patient will come out of my office and go to the office next door and get veneers done. And the dentist maybe will believe genuinely or want, I don't know. You know, I've always said, see, I speak in conferences, Zayham, right? And I lecture worldwide. And in my lectures, I always ask 3 questions. Check this out. 3 questions to all dentists.
You ask to the dentist?
To the dentist. Yeah. So I get the audience to participate. And then I'm like, okay, guys, I've got 3 questions for you. The first question is, how many of you are doing veneers in their clinics? So a lot of dentists raise their hands, obviously.
All of them.
Yeah.
Even the surgeons raise their hands.
Yeah, true. And then the second question is, how many of you want to do more veneers in their practices? Because, you know, obviously it's more income. And a lot of dentists raise their hands because, you know, the more veneers you do, the more money you make, obviously. And the third question is, how many of you have veneers done in their teeth?
No, maybe.
And then you have maybe 2-3 hands out of 600 dentists attending the conference. So it's a bit hypocrite, you know.
Yeah.
I mean, I would be more tolerable for a dentist to do veneers if he's got veneers done on his teeth, you know.
Yeah.
Right?
Did you make veneers?
No, I don't. Do you?
No.
See, exactly. That's what we're talking about.
Yeah, exactly. But some of the patients they need veneers. Actually, there are the veneers there are 2 functions for the veneer. First, the functional, the biological thing. The other is the aesthetic.
Absolutely.
So if it's purely aesthetic, the patients just want to improve the aesthetic. Do you believe in non-prep veneers?
Yeah, well, it's a big debate to prep or not to prep. After Shakespeare, it's Amir. So to prep or not to prep, you know, a few years down the line, a few years back, I would be like, no, non-prep is not out of the question. Because the main concern with non-prep veneers is actually the over-contoured cervical area that could, you know, compromise the hygiene, ending up in food debris accumulation, and then you end up with gum inflammation and all of that. But nowadays, we have ceramics that could be manufactured in minimal thicknesses, reaching 0.3 millimeter.
And the bonding, the adhesive.
The adhesive, obviously, you want to sandblast the tooth structure because you want to remove the outer enamel layer that is rich in fluoride and will resist.
This one will come back
the
or
etching.
No.
No. Of course, I don't believe that non-prep veneers are reversible. Yeah. That's the biggest lie. That's a lie. That's not true. Non-prep veneer is the first step before conventional prep veneers. You know, like prep veneers. Again, to me, when I look at non-prep veneers, what are the indications? Why would you not need to shave a tooth? In how many situations you don't need to shave a tooth? How many? Just to change the color, right? Then maybe bleaching is enough.
Yeah.
Right?
Yeah, that's true.
It.
Yeah.
That's it. You know what I mean? So it's controversial. I don't do many of them. I rarely do them. But one scenario where I believe in non-prep veneer is peck-shaped laterals.
The peg shape.
Yeah, if you have two veneers on peg-shaped laterals, why would you have to
Peg
shave
shape
them?
is the narrow
Exactly,
lateral.
exactly. The lateral is
Humane.
already small, smaller than it should be. You've got spaces. You don't need to shave down. You just have to make sure that you mark the finish line, the area where the veneer stops. Even though if you're not prepping, you're just marking with a pencil where to stop the veneer. And then you know very well that the veneer will have a natural degradation in thickness and in color. So you can make sure that the cervical area of the veneer blends in with the untouched tooth and you're not changing the shade. So it's not going to have an impact.
But sometimes you have also small teeth and there are gaps or spaces between the teeth. Also, I think this one is we can.
Yeah, we could. Yeah, again, we could. But again, so many factors you look at. Obviously, as you said, the lip line of the patient. Because if you're changing the color, because those patients will close the space, right? But most of them, if they're going to do 10 veneers, they want to have a wider color.
Definitely.
So you're probably going to have the margins of the veneer going at the level of the gingiva, equi or subgingival, which could end up with an over-contoured cervical margin. So you look at the lip line. If the lip line of the patient is low, you can stop way before the gums, and that's not a problem. If the lip line is high and you want to go equi or sub with a non-prep veneer, well, you have to think of the hygiene of the patient. You want to make sure that the patient has an immaculate oral hygiene for things not to degrade over the time. What I'm trying to say is 10 years ago, I would be like, no, non-prep veneer is a definite no. Now, it's still a no.
But some of the cases.
But very small number of cases, I would be like, you know what, why not, looking into the lip line of the patient, looking into the hygiene of the patient and all of that.
What do you do for the gummy smile patients?
Very good question.
The gummy smile is when the patient's smiling and showing more.
A lot of the gum, more than 3 millimeters.
More than 3 millimeters.
So any visual display of the soft tissues over 3 millimeters is classified as a gummy smile.
What is the solution for the gummy smile? Because some of the patient has a gummy smile and they don't know where to go, because there are many solutions for that, right?
Yeah, definitely, 100%. So first of all is to decide whether you need to correct it or not. That's a big question. Because sometimes some dentists are so much into their ego of going like, you know what, I want a perfect smile, I want to do that and do that. You can suggest it to your patient. But if it's a gummy smile of 3 millimeters and the patient is happy with it and just wants to get veneers done, you might not need to correct it. So it depends on what the patient wants. So that's the first line of action. Understand what are your patient's expectations. Because remember, it's an elective procedure. So obviously, once the patient has established that he's not happy with the gummy smile and they want to correct it, then you have different ways of, aligning it. I think the first number one thing is the treatment planning phase. To treatment plan the case properly. You know how we used to do before, the old conventional dentistry, we used to think first of biology, function, and then we thought about aesthetics. Nowadays, we start with aesthetics. So we have digital tools that allow us through a CBCT, a cone beam, a 3D smile design. You superimpose those two STL files and you can print out a 3D printed. I think you do it very well at Charismatic Lab. 3D printed surgical guide based on the endpoint. So you start from the endpoint and then you climb your way up. You could correct it with crown lengthening. Depending on the reason, of course, you have to know whether it's skeletal or not, if it's passive eruption or not, are the teeth smaller than they should be. But obviously you could use crown lengthening with gum and bone removal. You could just do gum reshaping. You could do lip repositioning, even though it's not a permanent thing. You could do Botox injections, and this Botox will bring the lips down. So there are many ways of tackling the situation according to the degree of the gummy smile. But I believe that these options should be discussed with the patient. Because some patients tell them, you know what, I can retouch the gums and give you Botox, versus I can correct it better and give you, we have to go through a crown lengthening procedure, cut the gums, cut the bone, wait 5 months, and then do veneers. And a lot of patients will be like, okay, how do I decide? Then you do a simulation, a mock-up, and the patient sees the result and then decides.
See it live in the
exactly.
mirror.
Yeah, exactly.
You can show it to them by video.
Absolutely. A video would be better.
Option,
in a mirror, but not a mirror like this.
Yeah.
Exactly.
And then when they get the mirror, the closer the mirror, the more you have to charge the patient.
No, but it's true. This is a commonly made mistake. You do a mock-up and you give a hand mirror to the patient. The problem with that? Because a mock-up is just a prova of what the result will be, but it's not an exact reproduction of the result. It's the mock-up is connected all in one piece. There might be voids, there might be bubbles. It's made of temporary material.
Yeah, and
So-
the patient will start focusing on this,
on the details.
defects. Yeah,
Absolutely. Whereas the idea and the purpose of a mock-up is to look at the bigger
overall
picture.
Yeah, the bigger picture.
Agree. And I've always said the moment you give a hand mirror to the patient, you awaken the radical part of the brain, and you lose the emotional link the patient can establish with the new smile.
Yeah,
So don't give a hand mirror. As you said, video is amazing. Emotional dentistry. Before and after
or
videos.
big mirror, but far away from it.
Or a wall-mounted mirror. A
Yeah,
wall-mounted
wall-mounted.
mirror on the wall. The patient gets up. Of course, you always have a couple of patients who will be smarter than the average and get close to the mirror.
wait, don't.
You know what you do
count
in
that,
this case? You buy a big wooden stick, and the moment they get close to the mirror, maybe not. So what I do is I use a small trick. I put a decoration, like it could be a
so you
sink, it could
don't
be
get
an
closer.
artificial plant, whatever it is, so that the patient doesn't really get close to the mirror and appreciates the overall outcome rather than focusing on the details.
Yeah, one of my friend, he told me the best thing he read an statistic, like the best or the most beautiful thing in the human being is the eyes, then the smile. But for me, the first thing I look.
That's debatable.
Yeah,
Let's not get there.
yeah. So to you, where do you look the first thing in the patient's face?
In the patient's
Yeah,
face.
because some of the clinicians, they look at the patient's pocket, right? I mean, don't look at
Bad question. So this part is completely deletable. so yeah.
No, we're talking here.
Yeah. Okay, let's focus on that
Not the
area.
pockets, yeah.
All right. So face of the patient. What do you look at?
For me,
Yeah.
I look at smile.
Smile. First thing.
Yeah.
Not being into dentistry. Like, let's say Iham is not a dentist.
I don't.
He's not a dental technician.
Yeah.
Has nothing to do with dentistry.
Yeah.
Would you still look at a smile?
I don't know. I never imagine myself out of the dentistry, to be honest.
You can't picture that, eh?
I can't picture that.
Yeah, we've been
Maybe the eyes, maybe, but not, of course, not the nose.
No, definitely not the nose. Even though it's the most prominent thing in a face, huh?
Yeah.
If you look at it, it's the most prominent thing, but no, not the nose. I would say, frankly speaking, when you look at someone, the first thing that you look at is the eyes. And then automatically the eyes take you to the smile.
Mm-hmm.
But you know why? Because the eyes are not dependent on the facial expressions of the patient. The eyes are there, whether the patient is smiling, grumpy, happy, sad.
So there is no dynamic on them.
Absolutely. They're there. So you can actually look at the patient and the eyes tell you a lot about the patient, about the person, sorry, I'm still thinking as a dentist. But the smile will tell you more about the person's personality. You know how there is a whole concept called visagism, and that was taken later on into dentistry called the visage smile concept, that relates the personality of the person with the shape of the teeth, the shape of the face. So I think a smile, the first thing I look at is the eyes, because it's the most easier.
You still look
thing
at
to
the eyes?
Yeah, still. As a person, not as a dentist, as
You're
a human being.
dentist. How can you isolate yourself?
I do. The moment I get out of my dental practice, I disconnect. I try not to be a dentist anymore.
I'm trying to believe you.
Well,
I know.
it's difficult to do. It's difficult to do, especially when you're out for dinner with friends, and then you get introduced to someone. They're like, "Oh, he's a dentist. Oh, really?" So I go, and they start pulling out. They do that all the time for some reason. Yeah. So, and they've got food inside their mouth. They're like, "No." But no, I try to disconnect, and I try to remain a normal human being. I mean, I work a lot. I work 6 days.
How many hours do you work a day?
I stopped keeping track.
So there are a lot.
Yeah, a lot.
More than 8 hours?
Yeah, sometimes more.
Really?
Yeah, more. There was a time where I used to teach in university more frequently. Now I teach only on Tuesdays, but there was a time where I used to teach in university, so I would teach from uni and then finish up uni at 12, let's say, and then go to the clinic till 9. So I'd have 8 to 9 hour shifts.
Obviously, you did a great job. You work very hard previously until you reached this level. But now, what is the situation? You still working?
As much.
Uh,
No,
no, I
not
don't
as
think
much.
so.
Not as
Yeah.
much. No, not as much, obviously.
Then you have family, you have body, you have you need to make sports, you have to go out with friends.
True. And this has started the last couple of years, to be honest, where I'm like, you know what, calm down, you know. So I've omitted certain things from my professional life, but I'm the kind of person who needs to keep going, you know, like it kind of drives me. And the moment things slow down, I'm not into it anymore. So I do still do a lot of international lecturing. I mean, I just came back from a trip. Next week, I'm in Turkey lecturing, then Jordan. So I keep myself busy as much as possible, and I enjoy that. Don't get me wrong. So it's kind of like tiring, but it's nice tiring, you know, in a very good manner. I enjoy that.
You know what I remember now? I remembered when we go to the restaurant, me and you, in the COVID time.
Yeah.
Post-COVID.
Yeah.
Yeah.
It was
you
during
were-
COVID with the
you-
mask on.
Yeah, you just stopped traveling.
That was bad.
Yeah. But you were at that time you were reacting like it was good for me. Now I see my life. But
I got to
I
know
don't
my
think
kids
so.
better to start with. You know, I'm like, oh, that's you, Adam. Hey,
how many
Ryan.
kids do you have, by the way?
I've got two boys.
Oh,
Two
mashallah.
boys.
Adam and
Ryan.
Ryan.
I've got 13 and 8.
Oh, 13.
Yeah, 13. Yeah. The old one is a big boy now. He's a big boy. So yeah, during COVID times, I discovered that I was good in cooking. You know, I lived my life, a big portion of my life alone when I was in France, and I never cooked. I used to order. I used to cook pasta. I'll tell you.
Pasta.
And the first time I cooked pasta, I remember every time I didn't know that you have to put oil or butter inside the pasta.
What did you put?
I didn't put anything. So obviously when I
It's very
finished
dry,
cooking the
man.
pasta, it came out in one piece. It was like completely stuck. So one of my neighbors, I asked her and she's like, no, you got to put some butter or oil. So I started doing that. And she's like, you know what? The best way to know and find out if your pasta is cooked is while it's being cooked, you take it out and then you throw it on the wall. And if it sticks, that means it's cooked enough. You don't want to overcook it.
Yeah.
So if you came to my place at the time, you'd see my wall full of pasta because that's pretty much the only thing I know how to cook. But during COVID, I started cooking. I did a couple of nice dishes. My kids loved it.
Which cuisine?
I was
Algerian cuisine.
No, it
by
was
the way, is
Algerian.
amazing.
It's amazing. It's you know the funny part about Algerian cuisine is it differs. Like you go from east to west, different ways of cooking. The taste is completely different. Everything is so much different. You go from the north to the south, completely different. So you have like multiple cuisines in one country. I mean, of course, Middle Eastern food is amazing. Don't get me wrong.
Yeah.
But it's very similar. Like I've been living in the area for a long period of
No,
time.
actually, it's not similar.
I can't tell the difference between Syrian and
Yeah,
Lebanese.
Syrian, Lebanese,
Palestinian, Jordanian.
Jordanian,
Yeah.
they are quite similar.
But
But
if
if
you
you
go-
go to, for example, if you go to Egypt, it's different. If you go to
Egypt is completely different.
if you
yeah.
go to Libya, Tunisia, Algeria, and Morocco, it's quite
Completely
different.
different.
Completely different.
But that's what I'm trying to say. In Algeria itself, my wife is from the east of Algeria. All right, from a city called Biskra. So the way they cook is completely different from Algiers, the capital where I come from. Like the way my mom cooks and the way my wife cook is completely different.
Which one is better? No need to answer.
That's gonna create a big problem. Still want to eat.
I want to live my life.
Exactly.
So that's the yeah. So traveling, you enjoy traveling, right?
Yeah,
Actually, traveling is broaden the mind always.
definitely. And traveling in a professional level allows you to get to know dentists from different backgrounds, different cultures, building relationships, interacting, understanding cultures. And it's also because you know when I go lecturing, there's also the social aspect of it. It's not about again, it's something I love doing, transmitting knowledge, sharing tips. I learn every time I'm lecturing. I learn from other dentists, so we give and take. But the social aspect of it is one of my favorite parts of the whole
And traveling.
Yeah.
And also you travel for free.
Yeah, of
This is
course.
the best part.
Actually get paid for it. It's even better.
You get paid to it, yeah. That's true. Which part of your career you enjoy more? The dentistry, practicing dentistry, or the education part?
It's actually what I was about to say earlier. When we first started this podcast, I started developing how I was lecturing, but I forgot to mention that everything I do in education is only, let's say, 20% of of my professional activity. I mean, yes, I do lecture locally. We have an academy, the Elite Academy. We do courses for the last 12 years in different parts, in different fields of dentistry. I lecture internationally. I travel. A lot of people see me traveling, but I travel in and out. Like I'm there today. I have a lecture at 3. I leave at 10. I come back 9 p.m. But 80 to 75% of my professional activity is in the clinic. So I would say clinical work. I consider myself a
really?
clinician. Yeah,
I didn't expect that.
No,
To be honest, yeah. I
I
saw you on the stage many times. Like I feel like you are very ambitious what you are doing in education, but I did not see you in the chair side.
see. I think it's got to do. I mean, I've sent you some of my work
Yeah.
before. We've had the chance to work together. I think it's got to do with one thing. I've tried not lecturing for a while during COVID.
Yeah.
I survived.
Okay.
I don't think I will be able to, not practice dentistry. I can't picture myself not
Makes
practicing,
sense.
And then the whole lecturing thing can only happen if you have clinical experience, expertise, you do cases, you share your knowledge, you share your mistakes. Those dentists around the world lecturing worldwide, they're not super dentists. They've just made mistakes, they've learned from them, and they're sharing them with the others. So unless you make those mistakes, you can't really share the ways to avoid them and to overcome them. So no, I definitely clinical work.
What's the best part in clinical work? When you feel yourself like you really achieve something?
So the
What
common
makes
thing,
you just going on?
as silly as it sounds. All right. So the common thing everybody would say, obviously, would say, oh, you know what? When I deliver my restorations, the patient's happiness, the way they look at the smile, and all that emotional stuff, which is true.
Which is true.
Which is true.
Yeah.
Which is true. But more realistically, as a dentist, for example, digital dentistry, I scan,
Yeah.
but I still take physical impressions. Even if I do an amazing scan,
Really? Why is that?
it's the satisfaction you get from an impression coming out with finished lines well defined. That's a psychological satisfaction that me as an older dentist still enjoy having.
You are a young generation.
I mean, still, to a certain extent. I mean, the younger ones maybe did not because they started off with digital scanners. We did a lot of physical impressions. We enjoy taking physical impressions. And that thing when you pull out and you got the cord coming out with the impression material, and then you see the margin, and then you observe. I do my digital. So all my labs, all the labs we work with, I send them a digital scan and I still send them a physical impression.
Really?
Yeah, I love it.
I see.
It's just because not every time, of course, that's when I have time. If I'm running late, then I'll just do the scan and get it over with. But whenever I have the time, I will still take a digital impression just to get that self-satisfaction.
Did you know that they are throw it?
Yeah, of
When
course.
they-
Most of them tell me we're not even going to pour it. I'm like, yeah, it doesn't matter. Don't tell me. As long as you,
Return
I
back
was
the
happy.
tray, just the tray.
You know what? Sometimes I don't send it. Sometimes I take it, I enjoy it, I look at it, I'll take a picture of it, and then
So
I'll
whenever
just
you are angry, you can bring one of your kids and take impression for him. You'll feel relaxed, right?
exactly.
When the patient comes to you, and mainly they come for aesthetic, right? What is the first thing or what is the criteria you make to deliver a beautiful veneers or crowns for your patients? Because it's not only the smile, right? It's not only here. It's not only in this frame, right?
Sure.
It's not only here. So what's the criteria you follow?
Many things, Iham. I mean, what makes you, different is that you think outside the box and you're more aware about the importance of a smile. As you said, it's not localized in the area where the oral cavity is. My job, my job is to meet the patient expectations. So I've always said, give the patient what they want, as long as what they want does not conflict with your treatment or does not compromise the patient's health. So I would still give the patient whatever they want in terms of color, shape, size, even if I don't fully agree on it, because it's an elective procedure.
But you give them your view in it.
Absolutely. I give my opinion, I'll share it. I will actually defend my opinion through mock-ups. So I will give 1, 2, 3 mock-ups if I've got to, just to prove my point. But if the patient wants to have, for example, very common, the color, the shade. Some patients want bleach shade veneers. I mean, and they're dark skin. I know they don't look artificial, but if this is what they want, this is what they want. So give the patient what they want as long as what they want does not compromise your treatment or compromise the patient's health. Because again, this is an elective procedure. So my job is first of all to understand what the patient wants. So the first visit is the most important one. When I sit down with the patient talks to me, what they expect from the treatment, and I write down everything. I'm like a first grader on his first day at school, taking notes of everything they say. Because to me, it makes a difference. Because most people, when you talk about some veneers, they assume it's going to be 10 upper, 10 lower. When in reality, it doesn't have to be.
Exactly, yeah.
It could
Sometimes
be maybe 4, 6, 8, 10. I don't enjoy doing veneers on the lowers, for example. The lower teeth are small, less enamel, more forces, aesthetic impact is not major. So if I can do a double bleaching, for example, on the lowers and then veneers on the uppers, it'd be amazing. So again, but if the patient chooses BL1 veneer, then I have no choice but to involve every tooth that looks in the
But
smile.
you try your best to convince them that this is something is not natural.
But if this is some patients come and they want this, and I tell them, no, but it's not going to look nice. It's going to look artificial. Like, yeah, we want people to know I've got veneers done. So it's their right. It's an elective procedure. You cannot take it away from them.
Yeah.
At the end of the day, it's something they could do or not do. For example, if a patient comes with pain on a wisdom tooth that requires extraction, I'm not going to do root canal. I'm going to send it to root canal. I'm going to do the extraction because the tooth is badly destroyed and it's under the gums. I'm the healthcare professional. It's my decision to decide if the tooth stays or comes out. If a patient needs a root canal, I'm not going to do a filling just because the patient doesn't want to do a root canal. So that's a medical decision.
Yeah, but for the aesthetic, then there is...
So patient expectations, understanding it is what drives me and what leads me into the treatment.
But I notice now a lot of patients, when they go to the clinician, they ask him, I need like this smile. And maybe this smile will not suit their face,
Absolutely.
right? So how you convince them?
I had a patient, now that you bring it up, I had a patient the other day who came up and started scrolling down in her phone, and then she pulled a picture of Angelina Jolie.
Yeah.
And she's like, I want to look like her after the treatment.
And she looks like...
She didn't say the smile. She said she wanted to look like her. So that's very high expectations. Some patients, for example, do not understand that what we do is teeth and smiles. We cannot, for example, there's a lip canting. We cannot fix that. It has to go through surgery or whatever. So I understood that she had very high expectations. I was like, deep down inside, I was like, you need a plastic surgeon. You don't need a dentist.
You don't need me.
Exactly. There's so much more to do. But what I'm trying to say is, it's very difficult to convince those patients that smile might not suit them. But the best way to do so is when you do your smile design, for example, or when you do your wax up, when you do your mock-up, whether we're doing it digital, obviously, but if you do it analog, when you do your mock-up, you show them what they want, and you show them what you think would look nice, and let them decide.
But again, the mock-up will not look exactly like the
Correct.
final. So because there will be some variation.
Absolutely.
Right? Especially with the color and the material, because it's different.
Yeah.
And this is the dilemma, actually, most of the clinicians face it, because you cannot show the patient what's the final result. Right.
So in these patients specifically, I would do two types of mock-ups. So the first mock-up, first of all, I would use flowable composite, not temporary material. So I'll have a transparent silicone key, for example, or a vacuum tray so that I can light cure the composite. So that's a little bit more optically nicer than temporary materials. The second thing is I'll do a first mock-up before the preps. Then, of course, the patient will agree on the treatment as an idea. But then once I prepare, I'll make a second set of temporaries that could be lab-made provisionals based on, for example, I could make 2 sets today, just after this podcast. I've done veneers on a patient yesterday. I've done chair-side temporaries the way I designed it. And now I'm making lab-made provisionals the way the patient wants to design it after the modifications she has requested.
Then you show them both.
Exactly. And now after at 5 o'clock, she's coming. I'm going to take off the old temps, show her the new temps. And then she could decide accordingly. It's, again, as you said, once you prep, it's a bit closer to the final outcome. Before the preps is very difficult because you haven't prepped. Some parts will be thin, some parts will be thick. Ask the lab to make them with PMMA, right? It looks nice. The problem with having very good, nice looking temporaries, and it's a problem I
Yeah, they will
faced.
higher the expectation.
And the patient won't appreciate the final result. Some patients, because they keep the temporaries for like 10 days, 2 weeks, they come back and they're like, oh, but I like the temporaries better. Because they got used to it,
Yeah,
it's
it
been in their
happened
mouth.
with me a lot.
Exactly.
Yeah.
So that's the only issue you might end up facing. But again, there is not a clear solution to every single problem.
That's true. And do you suggest the patient, because you know, the smile is related with the face, character, with the personality, right? But sometimes you need, for example, we did the veneers for one of the patients. She liked it and she was amazing. She came back to the same clinician after maybe 2 months, and she wants to replace them. I don't like my smile. Okay, but you agree about it. No, she doesn't. She wants to change it. But what did she do is she made a filler on her upper lip. So her filler is like, you know, the upper lip like terrace. So you can take shisha on top of it. And it's hiding the light, and the teeth is changing. So do you recommend the patients to go and do the plastic surgery before they come to you?
Yeah, again, so it's something you have to discuss with your patient before you do any smile makeover. I mean, again, so I'll be lying if I said I do it systematically with every patient. But when I see a female patient who's done some work in her perioral area, like Botox, fillers, whatever she's been doing, I always bring it up. Are you planning to do further? Are you going to do something else? Because if you are planning to, you might as well do it before we do the smile makeover, and explain that, you know, once the veneers are in place, this is something very important. And it's actually, written on a paper, and the patient signs on it, like a disclaimer where the patient understands that once the veneers are in place, they can't be changed. I don't mind repeating mock-ups. Like I've done 3-4 mock-ups to some patients who had high aesthetic demands. I don't mind changing the set of veneers 2-3 times if I have to, sending it back to the lab, modifying on it accordingly. But once they're in place, they're in place.
Yeah.
And if the patient approves it, I mean, the patient is an adult, you know. And if they approve it, then it's done, you know. And if they want to replace it, then obviously they're going to have to be charged.
Yeah.
I would say that obviously I probably won't be charging the full amount again because, you know, it's humanly not right. But I would still charge to cover up my expenses and lab expenses, obviously.
Yeah, that's true. Okay, Dr. Amir, thank you very much for being here. It was a very nice podcast.
You're welcome.
And thank you very much for watching, and we'll see you in the next episode.
See you soon. Take care.
And Amir in Arabic means the princess. Dr. Amir Hadjhamou.
Not the princess. Not the one.
The prince.
The prince.
Okay, your remake.
بعد إمام خليفة أمير حجحمو ورانا انتما.
He's a boxer. He's a Transgender.